Welcome back, everybody, to ModernMedics.
Today, we're going deep on magnesium and phosphate.
Really important electrolytes.
Yeah, but maybe not the ones that immediately come to mind, right?
Not like sodium and potassium, for sure.
Right.
But they're critical.
Oh, absolutely. If these get out of whack, it can really throw the body for a loop.
Big time. Energy, heart rhythm, bones, nerves, muscles, you name it, they're involved.
So no matter if you're prepping for exams or seeing patients every day,
knowing this stuff inside and out is key.
For this deep dive, we've gone all in on the latest research and guidelines.
Current as of April 3rd, 2025.
We're talking up to date KDI Go for CKD MBD. Nice guideline.
Harrison's the classic.
And even exam trends, what's actually showing up on those tests.
From 2015 all the way to now, using UWorld, AMBSS, PACE-TIF.
Our goal is to make this really practical,
Bridge that gap between the science and the bedside.
The why and the how do we actually fix this?
We'll walk through a case, a really vivid one, to make these points stick.
And pull out those exam relevant bits you got to know.
All right, so let's dive in.
Okay, picture this.
45-year-old guy.
20 years of heavy drinking.
Lands in the ER, seizures, muscle cramps, the whole 9 yards.
Tetany, that's always a red flag.
Classic presentation. If you check him, you're going to see it.
Sign facial twitching when you tap that nerve.
Trousseau sign, inflated blood pressure cuff, hand spasms up.
His labs are a mess.
Magnesium way down, 1.2.
Normal's 1.8 to 2.6.
Calcium also low, 7.5.
8.5 to 10.2 is where it should be.
Potassium's down to 3.0.
Got to keep that 3.5 to 5.0 in mind.
And phosphate 2.0, not looking good.
Normal's 2.5 to 4.5.
His ECG, prolonged QTC, 480 milliseconds.
Arrhythmia risk is through the roof.
What's the first instinct here? Low calcium, Tetany got to fix that, right?
Yeah, seems straightforward.
They give him calcium gluconate, 1 gram IV over 5 minutes.
Standard protocol.
But here's the catch. Calcium doesn't budge. Tetany doesn't improve.
So that's got to make you stop and think.
Big time. If calcium isn't responding, what's the absolute next step?
This is where it gets tricky.
It is. Calcium's not the whole story.
You have to suspect there's something else going on.
Yeah, and in this case, it's magnesium.
Low magnesium can really mess with calcium.
Think of it like this. Magnesium's the conductor, calcium's the orchestra.
Without the conductor, the music's all over the place.
Exactly. Low magnesium, you get less PTH.
Parathyroid hormone.
The hormone that tells your body, hey, we need more calcium.
So even if you give calcium directly, it's not going where it needs to go.
Bones, kidneys, they need magnesium to respond to PTH.
And then it gets even worse because it's not just the calcium.
We've got hypokalemia, hypophosphatemia.
Plus that scary long QTC interval.
Huge risk of Torsades de points, could be fatal.
And the chronic alcoholism is likely the root of all this.
20 years of it, it takes its toll.
Poor nutrition, direct organ damage, electrolyte handling goes haywire.
It's a multi-system breakdown.
So let's unpack magnesium first.
Let's do it.
Normal range, we said it, 1.8 to 2.6.
But that's just what's in the blood, tiny fraction of the total.
The vast majority is tucked away inside cells, right?
Where 60% is actually in our bones.
It's a busy mineral. Over 300 enzymatic reactions rely on it.
It's like the ultimate multitasker.
ET passes, those pumps that keep our cells running.
Sodium potassium pump, a major one.
DNA and RNA polymerase, that's our genetic blueprint.
Can't replicate or repair without it.
And adenylate cyclase, the CAMP signaling pathway.
Cellular communication central.
So energy production, genetic stability, cell signaling, all magnesium dependent.
All crucial for life.
And you mentioned heart stability. How does magnesium help with that?
Calcium's like the gas pedal in heart muscle cells.
Makes them contract.
Magnesium's the brakes, keeps things from going too fast.
Modulates those L-type calcium channels.
Too much calcium, you get arrhythmias.
Like the prolonged QTC we saw in our patient.
Precisely. Magnesium keeps that in check.
And what about those muscle cramps and seizures?
Magnesium and calcium are always in this dance, competing.
Especially at the neuromuscular junction.
Where nerves talk to muscles.
Magnesium helps regulate neurotransmitter release.
Keeps the nerves from firing too easily.
Low magnesium, those nerves are on overdrive.
Tetany, cramps, seizures, that's what you get.
Okay, so we know the body needs magnesium.
And it stores it primarily in bone.
About 25 grams in total.
60% bone, 39% inside cells.
Just 1% floating around in the blood.
Of that, only 2/3 is the active form.
The ionized magnesium that our tests measure.
Good point.
So how do we get magnesium? Food, right?
Yep. Nuts, seeds, leafy greens, dark chocolate.
The good stuff.
We should be getting 300, 400 milligrams a day.
But we don't absorb all that, do we?
Nope. maybe 30 to 40%.
In the jejunum and ileum through those TRPM6 channels,
And they're finicky.
pH, certain growth factors all can affect absorption.
Conditions like Crohn's can really throw things off.
So after absorption, the kidneys take over.
The kidneys are the control center,
Filter about 2,400 milligrams a day.
but they reabsorb most of it, like 95 to 97%.
Three main parts to that.
Proximal tubule, about 10 to 15% reabsorbed there.
Passively between the cells,
And the thick ascending limb of the loop of Henlo, that's the big one.
70% reabsorbed there.
Paracellular, driven by that positive charge from NKCC2.
Loop diuretics like furosemide,
They block NKCC2, so you get magnesium waste,
important to remember.
definitely. And then the distal convoluted tubule,
DCT for short.
that handles the last 5 to 10%.
Active transport uses those TRPM6 channels again.
And this part is regulated by a bunch of things.
EGF, insulin, those upregulate it.
Acidosis, cisplatin, calcineurin inhibitors, those inhibit it.
So our alcoholic patient, how is his magnesium system so messed up?
Multiple hits.
His diet's probably terrible.
Less than 100 milligrams a day, probably.
Alcohol can cause diarrhea too.
Less absorption in the gut.
But the main issue is the kidneys.
Direct toxicity from the alcohol, especially to that thick ascending limb.
And that messes with magnesium reabsorption.
Less magnesium stays in the body, more goes out in the urine.
You mentioned the sodium-potassium pump earlier.
Crucial for every cell.
Keeps potassium inside, sodium outside.
Right.
Magnesium is essential for that to work.
It binds to ATP to make Mg-ATP.
That's the fuel for the pump.
Without magnesium, the pump stalls.
Potassium leaks out, you get hypokalemia.
Exactly what we're seeing in our patient.
And the link with PTH.
Magnesium deficiency affects the parathyroid glands directly
They sense calcium levels in the blood.
through the calcium sensing receptor.
Low magnesium messes that up.
Less PTH gets released.
So even if the bones and kidneys could respond,
There's less signal telling them to do anything.
it's a double whammy.
Makes the hypocalcemia even worse.
Okay, phosphate now, what's its deal?
Totally different player, but just as important.
Normal range 2.5 to 4.5, we said.
It's all about energy, structure, and balance.
Part of ATP, the energy currency of our cells.
Makes up the backbone of cell membranes.
DNA and RNA too.
Crucial for pH buffering. Keeps things from getting too acidic.
And of course, bone. A huge chunk of our phosphate is there.
85%, in fact. Part of hydroxyapatite,
How much phosphate do we need daily?
800 to 1200 milligrams.
Dairy, meats, nuts, legumes, good sources.
Most absorption happens in the duodenum and jejunum.
Through that NaPi transporter.
And vitamin D calcitriol, it really ramps that up.
Calcitriol also helps with bone resorption and phosphate reabsorption in the kidneys.
It's a multi-talented hormone.
Kidneys are the main phosphate regulators, right?
Yeah, filter about 5,000 milligrams a day.
Reabsorb 80 to 90% of that.
Happens mainly in the proximal tubule.
NaPi and API transporters.
TTH and FGF23 are the key regulators.
PTH actually decreases phosphate reabsorption.
By making those NaPi transporters disappear.
FGF23, it's released by bone cells when phosphate's high.
And it does the same thing, less reabsorption, more excretion.
It also inhibits calcitriol production.
A nice negative feedback loop.
Keeps phosphate in check.
The distal nephron does a little bit of a phosphate reabsorption, but it's not the main player.
Okay, so back to our alcoholic patient. His phosphate was low.
Makes sense, given the whole picture.
Not enough in his diet to begin with.
Probably less than 400 milligrams a day.
Alcohol can mess up absorption in the gut.
Plus, direct kidney damage from the alcohol.
Leads to more phosphate spilling out in the urine.
It's interesting, you'd think low magnesium might actually help with phosphate,
Yeah, by lowering PTH, maybe less phosphate would be wasted.
but that's not what happens here.
The malnutrition and direct kidney damage seem to be more important.
Plus, severe hypophosphatemia on its own is bad news.
No ATP, if cells can't make energy,
You get anaerobic metabolism, lactic acid builds up.
worsens acidosis, contributes to weakness, even tetany.
It's a cascade of badness.
Okay, so we've got a patient with either low magnesium or low phosphate.
Got to figure out why, right?
That's key for treatment.
For hypomagnesemia, first thing is serum magnesium below 1.8 is low.
Then we calculate the fractional excretion of magnesium, the FEMg.
Tells us where the magnesium's being lost.
FMG, over 2-3% kidneys are wasting it. Could be diuretics, certain drugs, alcohol, even genetic kidney problem.
FMG, less than 2% kidneys are holding on to it.
Means the loss is happening before the kidneys.
GI losses, maybe not enough intake.
Makes sense.
For hypophosphatemia, it's similar.
Serum phosphate below 2.5 is low.
We can calculate the fractional excretion of phosphate, APO.
Or measure the total phosphate in the urine over 24 hours.
FEPO over 5%, or 24-hour urine phosphate over 100 milligram kidneys are wasting it.
Hyperparathyroidism, Fanconi syndrome, vitamin D deficiency, certain meds, FGF23, all possibilities.
If those are low, then the kidneys are trying to conserve phosphate.
The low level is likely due to it moving into cells or just not enough coming in.
Okay, causes of hypomagnesemia, there are a lot.
Let's break it down.
GI losses are a big one. Chronic diarrhea, malabsorption, vomiting.
Nasogastric suction, pancreatitis, those can cause it too.
Then there are renal losses, loop diuretics like furosemide.
Thiazides, certain drugs like cisplatin, aminoglycosides, amphotericin B.
Calcineurin inhibitors, even long-term PPIs.
Wow, that's a lot of meds.
And genetic disorders like Gittleman and Bartter syndromes.
Those mess with renal magnesium handling.
Then there's just not enough coming in malnutrition, alcoholism.
Prolonged TPN without enough magnesium.
And a few endocrine causes: primary hyperaldosteronism, hyperthyroidism,
hyperparathyroidism, hungry bone syndrome. Those can contribute too.
It's really a wide range of possibilities.
What about hypophosphatemia? What causes that?
3 main things.
First, intracellular redistribution phosphate moves into cells.
Happens in refeeding syndrome, DKA treatment, acute respiratory alkalosis.
Sepsis, critical illness, those can shift phosphate too.
Then there's decreased absorption or intake.
Severe vitamin D deficiency, chronic use of phosphate binding antacids, starvation, severe malnutrition, those can deplete phosphate.
And lastly, increased renal losses, phosphaturia.
Primary or secondary hyperparathyroidism, Fanconi syndrome, carbonic anhydrase inhibitors, X-linked hypophosphatemic rickets, all those can cause phosphate wasting.
There are a few less common causes too, like acetaminophen overdose or hemolysis.
So for our alcoholic patient, it sounds like he got hit from all sides.
Yeah, poor diet, probably less than 100 milligrams of magnesium and 400 milligrams of phosphate a day.
Plus, alcohol-induced kidney damage, the thick ascending limb for magnesium, more generalized damage for phosphate.
And likely some chronic diarrhea on top of that.
And then the low magnesium just spiraled, making the hypocalcemia worse.
By messing with PTH.
It's all connected.
It really is. Okay, so now we know what we're dealing with.
How do we actually fix it? Let's start with hypomagnesemia.
All right, so the approach depends, right? How low is it? And are there symptoms?
Makes sense.
For severe hypomagnesemia, below 1.0, 1.2, especially with seizures, tetany, EKG changes.
QTC over 400/6,500, arrhythmias, that's serious.
You got to go IV magnesium sulfate, 2 grams, dilute it, give it over 10, 20 minutes.
Might need to repeat if things don't improve.
Then you usually start a continuous infusion, 4 to 8 grams over 12, 24 hours.
For example, 4 grams and 500 milliliters of normal saline, run it at 20 milliliter per hour.
That gives you about 0.33 grams per hour.
You have to monitor them closely.
Magnesium levels every 4-6 hours initially.
Continuous EKG or serial EKGs.
Blood pressure, heart rate, respiratory rate. Watch those reflexes.
Loss of reflexes can be an early sign of too much magnesium.
But if it's not that severe,
Like 1.3, 1.7, no symptoms.
overall magnesium is usually fine.
Magnesium oxide is common, but the bioavailability isn't great.
And it can cause diarrhea.
Magnesium citrate, lactate, or gluconate might be better tolerated.
Slow release formulations can help too.
What about if the kidneys aren't working well?
That's tricky. Got to be really careful with IV magnesium.
Lower doses, slower infusions, check magnesium levels even more often.
Aim for a GFR over 30 milliliters per minute, but adjust based on the patient.
And watch out for magnesium toxicity.
Loss of reflexes is the first sign, then drowsiness, low blood pressure.
Slow heart rate, breathing problems, even cardiac arrest if it gets really high.
So for our alcoholic patient, what do?
He's seizing, tetany, magnesium is 1.2. That's IV mag sulfate for sure.
2 grams stat over 10-15 minutes, then a maintenance infusion.
4 grams and 250 milliliter normal saline, maybe 21 milliliter per hour over 12 hours.
But adjust that rate based on his kidney function.
We'd also start potassium replacement carefully.
And after the magnesium is running, check that calcium again.
Often it'll start to come up on its own.
If not, and he's still having symptoms, then maybe some IV calcium gluconate.
The key is fixing the magnesium first.
That's the foundation.
Okay, hypophosphatemia. What's the game plan?
Similar idea, severity and symptoms drive the approach.
If it's severe below 1 milli-GDL or 0.32 millimole,
Or any level if they're really sick, respiratory problems, muscle weakness, rhabdomyolysis.
altered mental status, seizures, hemolytic anemia, that's IV phosphate time.
Dose depends on weight and how low it is.
0.08, 0.16 millimole per kilogram over 4-6 hours for moderate.
Up to 0.32 ZAS, 0.5 millimoles per kilogram over 6-8 hours if it's really bad.
So for a 70 kilogram patient, severe would be like 2135 millimole total.
You can give it as sodium phosphate or potassium phosphate.
Each ml has about 3 millimole of phosphorus.
Choose based on their potassium level.
So for that 70 kilogram patient, 35 millimole dose, you'd need about 11.7 millimiller.
Dilute that in 500 milliliter of normal saline or D5W.
Don't use fluids with calcium in them.
Infuse it slowly over 6 hours, like 83 milliliters per hour.
And never ever bolus 5E phosphate.
That can tank their calcium.
Check phosphate, calcium, potassium, and magnesium every 6-12 hours during the infusion.
Aim to get that phosphate above 2.0, 2.5.
What if it's not that bad? Like 1.0, 2.5, no symptoms.
Oral phosphate is the way to go.
Kphos, neutral, Nutrifos, those are some options.
Aim for 500, 1,000 milligrams of elemental phosphorus 3 times a day.
That's about 15-30 milligram per day.
Usually for a few weeks, but it depends on the cause.
We have to be super careful with malnourished patients when we start feeding them.
Refeeding syndrome is a real risk.
Phosphate, potassium, magnesium all can plummet.
Start slow, 5-10 kilogram per day, then increase gradually.
And give thiamine, potassium, phosphate, and magnesium prophylactically.
Monitor electrolytes every day for at least a week.
Why is IV phosphate so risky for calcium?
It binds to calcium and forms calcium phosphate.
And that can precipitate in tissues, even cause kidney problems.
So if calcium's already low, think about giving calcium gluconate.
Before or at the same time as the phosphate, but through different IV lines.
Okay, what about the flip side? Hyperphosphatemia.
That's common in advanced CKD, especially on dialysis.
Mainstays of treatment are dietary restriction and phosphate binders.
Binders are taken with meals. They grab onto phosphate in the gut and stop it from being absorbed.
Non-calcium binders are usually preferred.
Sevelamer carbonate or hydrochloride, 800 milligrams 3 times a day.
Lanthanum carbonate is another option.
They don't have the same risk of hypercalcemia and vascular calcification as the calcium-based binders.
If those don't work or aren't tolerated or are too expensive, then you can use calcium-based binders.
Calcium acetate, 667 milligrams 3 times a day, gives you 169 milligrams of elemental calcium per tablet.
Calcium carbonate is another one.
But you have to watch calcium levels closely.
Every 2-4 weeks initially. If the goal is to lower cardiovascular risk, don't use calcium-based binders first.
What about when phosphate's really high, like in tumor lysis syndrome?
That can be scary. Phosphate over 6, high potassium, high uric acid.
Low calcium, acute kidney injury, it's a whole mess.
First thing is fluid, lots of them.
Normal saline, 1 liter bolus, then 150, 200 milliliter per hour.
Aim for over 3 liters of urine output per day.
You also got to get that uric acid down.
Rasburicase is the best for that 0.15, 0.2 milligram per kilogram IV once.
So for a 70 kilogram patient, that's like 10.5, 14 milligram.
Allopurinol is more for preventing high uric acid, not treating it acutely.
That's super important to remember.
Really? Okay, so let's shift gears a bit.
Exam time.
Time to test that knowledge.
What are some common scenarios that pop up on exams?
We've seen some trends from 2015 to now.
Let's hit the highlights.
First one, CKD stage 5 on dialysis.
Phosphate 6.5, calcium's 9.0, PTH is 400.
What do we do?
First, restrict phosphate in their diet.
And start a non-calcium binder sevelamer. 800 milligrams 3 times a day with meals.
That high PTH means secondary hyperparathyroidism.
You might carefully try calcitriol or calcimimicking.
But watch those calcium and phosphate levels like a hawk.
Don't jump to calcium-based binders because of that cardiovascular risk.
Second scenario, pregnant patient preeclampsia.
Getting magnesium sulfate, 2 grams per hour for seizure prophylaxis.
She gets drowsy, no reflexes. Magnesium's 8.0.
That's magnesium toxicity.
What do we do?
Stop the magnesium, give calcium gluconate IV 1 gram over 3 to 5 minutes.
That's the antidote.
Monitor her breathing, keep her stable.
You might restart the magnesium later at a lower dose, but it depends.
The 2024 ACOG guidelines have the latest on that.
Key takeaway calcium gluconate is the immediate fix for magnesium toxicity.
Third case HIV patient on tenofovir disoproxil fumarate, PD.
He's got muscle weakness, bone pain,
hypophosphatemia, glycosuria, but normal blood glucose, aminoaciduria, and a little bit of hypomagnesemia.
Sounds like Fanconi syndrome from the TDF.
Proximal tubules not happy.
If he's symptomatic from the low magnesium, hit him with 2 grams of IV mag sulfate stat.
Then switch to oral magnesium oxide or citrate. 400 milligrams 2 or 3 times a day.
Plus oral phosphate replacement.
TDF can cause mitochondrial toxicity in those proximal tubule cells.
For the long haul, switch them to TAF, tenofovir alafenamide.
Much less kidney and bone toxicity.
Been around since 2016-ish, a game changer.
What else have we got?
Let's keep going.
Okay, multiple myeloma patient, fatigue, bone pain.
Phosphate is 6.0, creatinine 2.5, uric acid is normal.
So hyperphosphatemia, but not classic tumor lysis.
Start sevelamer, 800 milligrams 3 times a day. Adjust the dose every 4 weeks.
This is likely myeloma cast nephropathy.
Leads to CKD, can't get rid of that phosphate.
Another one, ICU patient, severe sepsis.
Developing diaphragmatic weakness, can't wean off the vent.
Phosphase 1.5.
Classic hypophosphatemia causing respiratory muscle weakness.
ATP is depleted, can't power those muscles.
Give 5E phosphate right away, 20-30 millimole over 6 hours.
Monitor phosphate, calcium, potassium every 6 hours.
Next up, burn patient, 50% TBSA buns.
Hypotensive, bradycardic, lethargic, magnesium's 5.0.
Could be absorbing magnesium from topical treatments.
Like those magnesium sulfate soaks.
Stop the topical magnesium. Give fluids if they need them.
And calcium gluconate, 4 Phe, 1 gram, if the heart's acting up.
That's wild, absorbing magnesium through burns.
It happens.
Last one, DKA patient.
Phosphate might be normal or even a little high at first.
But after insulin and fluids, it drops.
That's insulin driving phosphate into cells.
Replete that phosphate maybe 15-20 millimole over 6 hours.
Don't forget about that shift.
These are some tough scenarios.
But they highlight what's really important clinically.
Okay, last bit, special populations.
Kids, older folks, cancer patients, pregnant women.
In kids, always think about inherited stuff.
Cystinosis, for example, lysosomal storage disease.
Damages the proximal tubules, leads to Fanconi syndrome.
Kids not growing well, peeing a lot, dehydrated, rickets.
Phosphate wasting, glycosuria, aminoaciduria, all red flags.
Treat aggressively, oral phosphate, alkali therapy, high-dose vitamin D.
And cysteamine to lower cysteine levels.
Older adults are at risk for hypermagnesemia.
From over-the-counter magnesium laxatives and antacids.
Milk of magnesia is a common culprit.
They might be weak, confused, drowsy. Then their blood pressure drops, heart rate slows.
Stop the magnesium, give fluids, and if they're symptomatic, IV calcium gluconate, 1 gram.
That calcium is key for hypermagnesemia.
In cancer patients, cisplatin chemo can cause chronic magnesium wasting.
Damages the distal convoluted tubule.
They might be fatigued, have muscle cramps. Magnesium's low weeks or months later.
Long-term oral magnesium is usually needed.
Citrate or lactate, 400 milligrams a day or more, but diarrhea can be a problem.
Sometimes they need IV magnesium too, like 2 grams a week.
There's a new drug, Amifostine, that might help protect the kidneys.
It's not widely used yet, but that could change.
In pregnant patients, magnesium sulfate overdose is a serious worry.
Can cause respiratory problems, even stop breathing.
If that happens, calcium gluconate IV stat, 1 gram, and stop the magnesium.
Ventilate if you need to. The 2024 ACOG guidelines have the details.
And lastly, there are those rare genetic tubulopathies.
FHSH, familial hypomagnesemia with secondary hypocalcemia.
GRPM6 mutation.
And FHNC, familial hypomagnesemia with hypercalciuria and nephrocalcinosis.
Autosomal recessive, Claudin 16 or Claudin 19 mutations.
Messes up magnesium and calcium reabsorption in the thick ascending limb.
Low magnesium, high calcium in the urine, kidney stones, nephrocalcinosis. It's tough.
One last update, TAF, tenofovir alafenamide.
Came out around 2016, a big improvement over TDF for HIV and HPV.
Much less kidney and bone toxicity.
A real win for patients.
So that was a lot.
It was.
What are the big takeaways? What absolutely has to stick?
Okay, number one, if you've got low magnesium, calcium, and potassium, fix the magnesium first.
It's often the key to getting the others back in line.
2, severe hypomagnesemia. 2 grams of IV magnesium sulfate stat.
Severe hypophosphatemia, 5E phosphate, but slowly 15-30 millimole or 0.10, 0.3 millimole over 4-6 hours.
Never bolus in and watch that calcium.
Hyperphosphatemia and CKD, diet restriction and phosphate binders.
Non-calcium binders are preferred.
Tumor lysis syndrome, fluids and Rasburicase.
And most importantly, understand why these things happen. Magnesium and PTH, phosphate and ATP, FGF23, loop diuretics and magnesium, it all matters.
Knowing the mechanisms helps you treat patients better.
We hope this deep dive was helpful. Thank you all for tuning into Modern Medics. Keep learning, keep questioning, stay curious, and keep rocking it out there.